in a nutshell, I love technology. Once we get further along, I will be sharing with you some of the things that I was able to do. I've created EMRs from scratch. My capstone project, which was really awesome, was really kind of explaining to people what we do, what you guys will soon have the opportunity to do. I will tell you that I love what I do, and I'm hoping that my enthusiasm of this particular profession will kind of bleed a little bit on you all, and then you'll share that love. So that's just a little bit about me. So right now there are about 11 of us on. I would love for you guys to start with just kind of giving me a little bit about you. I'm pretty sure that you have been in the same cohort, so you kind of know each other a little bit, but this is my opportunity to get to know you. One of the things I would like you to tell me is what brought you to this field, and where you're from. So I am going to call on you. Hillary, go ahead and let us know a little bit about you.
Hi. I actually wasn't part of the first module, so I'm like new. I had like transfer credits.
Okay.
I go by Hilly. I have 8 cats and 2 dogs because I'm crazy. I live in central Illinois, and I got into this field because I wanted something in the medical field that was kind of tech related, and something that I could hopefully in the future do from home because I kind of deal with like some chronic illnesses. So I'm looking for something I can enjoy without having to be on my feet all day.
This will definitely do it. Well, welcome. Jeanette. And if I say your name incorrectly, please correct me because I'm also learning how to pronounce your names as well.
That was fine. I go by Jay,
Okay.
and I live in California. I decided to switch my major from business to do this because I always wanted to be in the healthcare field, and like her, I like Hillary. I like that I won't be on my feet. I can eventually work from home. It's still dealing with patients, helping them out, just kind of behind the scenes. I just feel like there's more plus to it than what I was doing before in my life right now. So I don't know, I'm pretty excited about it. But yeah.
Awesome. Well, welcome.
Thank you.
Lindsay.
Hello.
Hi.
So originally I started off in the ultrasound technician program, but then COVID happened. So I decided that I wanted to switch programs, which I was also always interested in this as well. And then doing some research, talking to a few doctors, they did explain how this was such a growing field and it's really in demand right now. And just like everyone else, working from home was always a good option. And, you know, this program being fully online, that was really going to help out with working full time and, you know, having family and stuff.
Definitely. Well, welcome.
Thank you.
Robert.
Alrighty, well, I'm in Palm Springs, California. I have a degree in child and family development, and that didn't end up going in the direction that I wanted it to. Not really a livable wage there, in spite of the amount that needed to go into it. So I ended up forcing myself into retail because that paid better. So I figured with being on furlough from retail that it would be time to get my foot in the door in the medical field without being like in an ER. My partner is an ER nurse, and I know I can't handle that with all the stories that he comes home with. So I figured I'd get behind the scenes, get my foot in the door this way.
Awesome. Well, welcome. I'm trying to make sure I catch everybody. Rika.
Hi. So I'm Rika. I'm from Pasadena, California. I work already in medical records. It's going to be my 5th year. I got into this field. I was introduced by my past director, and she said, why don't you take the school with me? I said, oh, okay, I'll give it a try. So I'm here and hopefully gain more knowledge and maybe work in a hospital or something like that in the future. Maybe do coding or something like that.
Okay. Well, you'll see that there's so many opportunities that you will be surprised at the different places that you will be able to work at. So welcome. Okay, let's go down. Rossi, I want to make sure, I don't know if I said it right. Rossi?
It's Rosie.
Rosie, okay.
Yeah. I am currently in the medical field. I'm a medical assistant. I've been a medical assistant for 7 years. I've been a medical assistant for 7 years. We live in Las Vegas. My husband is Royal. He's also in this class. And same thing, from working from home would definitely be helpful because I have 3 little ones, so I would definitely want to be home with them more. So yeah, I mean, I definitely want to stay in the medical field, so I figured just, do this and kind of be in the medical field still.
Well, welcome. And just so you know, I have a little one. I've locked her out of my office right now, but every now and then you may see her bamming in and coming in. So trust me, we're definitely here for you all. All right. Sharimia, I know I butchered that. How do I pronounce that?
My name is Sherry May.
Sherry, okay.
But you can call me Sherry.
Okay, Sherry.
I'm from Los Angeles, California. I did get my medical assisting, but I realized patient interaction wasn't really my thing. So I currently work for a dialysis vendor behind the scenes of like administration side. So I wanted to continue my education, and I found this program, and yeah.
Okay. All right. And ironically, I work in the healthcare field by trade, but I chose surgical technology because my patients are always asleep. So my interaction with them is very minimum when, they're already, by the time I get them, they're already intubated and I'm just with my surgeon. So I definitely get that. Okay. Who did I miss? Let's see. Yes, go ahead. Yes, you.
Hi, I'm Roy Soto, but you can call me Roy.
Roy, okay.
I have 3 children, 2 daughters, 1 son. He's about to be a year old actually in a couple days.
Oh, happy birthday.
Yeah, it's almost his birthday. But I wanted to do this field because I'm a stay-at-home dad for the most part. So working from home is something that would work for me because my wife goes and she works all day, So, working from home is why I chose this field.
Awesome. And I like the fact that you guys are here to support each other and kind of like bounce off each other. So welcome.
We're getting it done. Yeah, it's good what both of us doing, definitely.
And then there's one more, but I can't seem to get your name. Gustina.
Yes, hello.
Hi.
I am Gustina. I'm from Louisiana, but we live in San Diego, California. I am a stay-at-home mom with 5.
Okay.
So this would be perfect for me.
Okay, awesome. And welcome. Welcome everybody. Thanks for sharing a little bit about you with me, as this is our real first official meeting. Now that we've got the formal introductions out of the way, like I said, I like to start each week with a quote of the day, especially with the climate that we're in, especially with everything that's going on. Sometimes we feel like things are impossible. We're stay-at-home parents, or like the babies are crying, or your partner's like won't stop. Sometimes it's good to know that nothing is impossible. The word itself says, I'm possible. So when everything starts to get everything starts to get tough and you feel like, oh my gosh, how am I going to make it? This feels impossible. Stop, breathe, and remember that the mere word impossible says that I am possible. And that's just my little quote of the week to kind of get me ready. Granted, I know that the quote of the week we get on Thursdays, but then you can carry it from this Thursday all the way to the next Thursday. All right. Okay. Now we're going to get into the subject matter. This is your first, for some of you, information technology course. What you'll realize is that a lot of the information that you're going to learn is going to be a recap from your healthcare classes from the past, because we as healthcare information technologists have to know what healthcare providers, our nurses, our doctors, our technicians, we have to know what they know so that we can implement and help them to do their job. All of our goal is to make sure that we increase and improve patient care. And that's what we're going to learn, the basics. with every course, you know, we've got to start from the forefathers, the beginning, when we look at early health information. Now, I get extremely excited when I teach. So if for some reason I'm going too fast, or there's something that you need to have me pause on or reiterate, just stop me, okay? Because my goal is to make sure that you really get the information and you enjoy it. I love teaching and I love what I do. And sometimes I'm too enthusiastic. So pull me back, be like, Miss Roulette, slow down. And I will make sure to slow down and give you examples and make sure that you understand what we're going to talk about. Okay, early history of health information management. Prior to the hospital, there were so many things in the beginning where people were doing things were getting lost, information wasn't being carried out properly, people were minimally documenting, patients were getting wrong medications and wrong site surgeries, and there was no real standardization. You know, with us right here, we're all in different parts of the West Coast. And it would be sad because, let's say hypothetically, I would go to a hospital in Vegas and my information could get lost in translation, and the gaps weren't being filled. And something had to change. So in 1918, things started to get better. In 1918, a standard was established. Medical staff and organizations and hospitals and things were starting to come in alignment. Membership was restricted, licenses were put into place, certifications were starting to look at, there were mandates, medical people had to be skillful in their jobs. They couldn't just show up like they were going to, you know, hey, I stayed at a Holiday Inn, can I do this suture? No, that couldn't happen. Things were getting put into place to protect the patient. Health record process was created, and it started to see a huge improvement in healthcare across the field, okay? Especially with regulations. It's so important to have these in place because ultimately our goal is patient safety. So even back in 1918, they started to implement baby steps, right? Because we still have a little ways to go, as you'll learn throughout this particular course. American Record Librarians of North American, was created in 1928, so 10 years later. Here's another thing that was coming into place. There are 58 charter members, as you guys can see, and it's known now as the Health Information Management Association. One of the things that I placed in your course is the link to the AHIMA. It's a really good resource to link on to kind of see all the different possibilities that you will be able to go through. You'll see the CEUs, you'll see which CEUs, meaning continuing education units. You'll see different extra certifications that you can obtain through the AHIMA. It's really working to promote the mission through informatics. We are transforming data in the health intelligence. We are allowing people to be able to have their information in the palm of their phones now. You know, before, someone being able to communicate with their doctor via phone telework was unheard of. But now, especially with COVID and all the other things that have transpired, it's more, people feel safer, right? If I can talk to my doctor and find out everything that I need to know at the palm of my hand versus potentially putting myself and my family at risk, right? So we are transforming and we're helping to bring individuals' healthcare information to them. Have I lost anybody so far? Okay, we're good. All right. Okay, like I mentioned in the beginning, we've got to learn the basics. So as we continue, now we're from 1928, we're going up to 1934, where we have now the first approved program. This is talking about CAHAM, Commission of Accreditation for Health Informatics and Information Management Education. They have a certification board. It's where you have your certification examination that I encourage everyone to take. And it's just another thing to kind of help to improve our healthcare informatics career field. I do have 3 dogs, so you may hear my greyhound and my dachshunds, just so you know. Um, when we're talking about KHAM, it's a voluntary peer review evaluation process that aims to ensure health information management programs meet common standards of education quality. So here we're again talking about standards. We're talking about requirements. We're talking about making sure that we are adhering to providing the best care and providing the best information possible. The accreditation by KHAM assures that programs meet the rigorous academic quality and competency standards established by AHIMA. Okay, so if you were to look and you're like, okay, KHAM and AHIMA, what's the difference? Well, one is assuring that the programs meet the requirements established by the other. With KHAM, you're looking at assessments, you're looking at site visits, they're coming and making sure that facilities are adhering to certain standards. I don't know about you, but I like that because now we know that we're stepping up our game and ensuring that information is being provided in the correct way. Different names of organizations. So these are just things it's good to know. The next couple of slides, we're just going to be showing you they're the names. So you have your American Association of Medical Records, your American Medical Record Association, Information Management Association, RHIA, when we're talking about Registered Health Information Administrator. And this can all be found on the site and the link that's provided on this PowerPoint, as well as on your welcome when you come to the first page of your course. Okay, I really encourage you all to kind of link in, look around, see what you see, and you never know, you may be able to be like, I like coding, I like this, I like creating EMRs, I like systems like Epic, but those aren't the only things we do. You may realize that, hey, maybe I want to go to a surgery center and help implement this, or maybe I want to go to a pharmacy and help out with this. So going ahead and looking at these governing bodies will kind of get you guys to focus on, what direction do I really want to go with this health information technology career field? Okay, I'll keep this up for a little bit just so you guys can kind of look over the credentials and the different bodies. I'm trying not to get distracted because of my dachshund. Okay, now we're going to be talking about things that are going to sound familiar to those of you who are already in the healthcare field, okay? Traditional practices. When we're talking about traditional practices, we're looking at the records, the stuff that's in the records, how we store our records, and how we retrieve them. I can assure you that when I was on the ship back in the 2000s, a little bit earlier, we would literally have the paper records. They were filed alphabetically and they were in a locked room, right? And when we would have to go retrieve them, we were going through, picking the records, filling out the information by hand, and then putting it back. And that was on the ship. There were different settings that we had to look at. The hospital has a different department where you go to medical records. Of course, with government agencies, they have also different settings to keep your records. There's consulting companies, and there's so much more. That's the traditional practice of back in the day. I call it back in the day, the olden days, where we would literally be taking the paper by hand, grabbing a piece of paper, and putting it back. Anyone who watches Grey's Anatomy, and I'm not a fan, by the way, just because sometimes I'm like, that is not what we do in the real OR. But you can even see the transformation from going from paper to electronics on that show. It's been on for 17 years. And I remember glancing at it because I was binging it this Christmas, right? Because there's nothing else to do. I was binge watching it, and I still don't like it, but I was like, this is something to watch. And I noticed, and that was one of the first things that I really paid attention to. The first couple seasons, they were carrying around medical records. They were walking around with in hand. And then probably about season 7 or 8, I don't remember. Then they started walking around with the iPad and the computer boards. And it went from they were handwriting the OR schedule to now it's an electronic EMR right in front of you. And I was like, wow, They are right there going from traditional to the new process. So when you have information management process or practice, we're looking at a holistic approach to managing by implementing different roles, controls, and matrix that treat information as valuable business assets. Your information is like gold. You don't want to just be passing it out. We don't want to just be like, hey, you get my social security card. Hey, you get my address. Hey, you get my diagnosis of appendectomy. We don't want to do that. We want to make sure that everything is protected and everybody is adhering to the rules to protect that information. I always get, what exactly is informatics? I cannot tell you throughout, every time I'm like, yeah, my master's is in healthcare informatics. And I'm always, what is that exactly? And then I go through this whole process of, well, it is the study of the structure, the behavior, and the interactions of natural and engineered systems. Basically, when I think of what I do, I combine healthcare with technology. So when I say the first part, they're like, what? So then I'm like, okay, healthcare and technology, healthcare and technology. This is where we bring your information from this paper to now this iPhone, this iPad, this laptop. And when you say that, they're like, oh, sweet, okay. It's a representation, processing, it's communication of information about you, your medical information brought to you at the tips of your fingers. It's a really emerging field, and I'm super excited that you all decided to come and join this. The infrastructure, what we do, we collect, we manage, we preserve, we store, and we deliver that information to where it needs to be. The right people. It's always on a need to know basis. And we help to secure that information so that the right people are allowed to get that information through your electronic health records, from information management, from the way we use it, from just analyzing that data to see what's going on. So the next time someone asks you about exactly what is informatics, now you can let them know it's where healthcare meets technology. And then they'll be like, okay, cool. And they may go further. And once they get further, then you can go ahead and explain even further what we do. Okay. So when we're talking about membership organization of the AHIMA, we're talking about a code of ethics that set forth values, ethical principles, standards that help inspire actions, because people are going to be looking at that. There are 5 code of ethics as we get down to the code of ethics. You're looking at the integrity. When we're looking at systems, we got to make sure that the integrity is on point. What is the objective? Why are we creating this system? Why are we creating or implementing this particular electronic health record as opposed to another one? What is the professional competency? Meaning, are we doing it for a surgery center? Are we doing it for a full hospital? Are we doing it for a private practice? Are we doing it for a pharmacy? We have to make sure that there's some type of confidentiality. Is a normal person walking off the side of the street, are they going to be able to come in and grab it and be able to expose everyone's information? How far do we want it to be coded? How far do we want it to be encrypted? And then the professional behavior of the individuals in that area. What is the, I always call it, what is the climate? What's the population? I know for me, being more military or coming from a military background, my climate is going to be a lot different from someone who started off in a civilian hospital or someone who started off in straight informatics. The climate is going to be a little bit different. So knowing the behavior of the facility that you're going to be helping is also extremely important. There are different categories. You have your active members, you have your premier membership, students. When you look at emeritus, I'm pronouncing it incorrectly, but basically all that is someone who was formerly holder of an office or a college professor or someone who's retired, they can still come back and get their membership as well. You have global membership, and anyone who is new to this whole field, which would be you all, you can also get a membership as far as the membership categories. Once again, I keep reiterating to make sure you go back to that site and just explore and see exactly what I'm talking about. Now, how does it operate? They have volunteers, there's staff, of course, with everything. There's going to be board of directors and some type of leadership. When we're talking about engagement of the people, how did you guys hear about this? You know, what got you into this particular field? There's always national committees, there's councils, there's workshops, there's so many different things to help make sure that we are staying up to date in our professionalism, okay? And with the structure of the AHIMA. I mentioned continuing education units. And those of you who are already in medical fields or in other places where you have to continue to keep your skills or provide information, you do it here as well. As a surgical tech and in the operating room as PA and everything in that whole field, we have to maintain our CEUs, or we have to recertify, relicensure, and all that. The easiest thing is once you get certified, just get your CEUs, because those tests are beasts. So continued education, they can come in a lot of different ways. Of course, you can always get the books from the different institutions and, you know, fill them out. There's workshops, there's courses, there's self-assessments that you can take, and there's so much more. Sometimes a lot of your facilities will provide you information that can help you actually get your CEUs. I know that Rady Children's, when they were looking at getting Magna status, anyone who had certifications and stuff, they would give a little extra money. And if you had experience in like Epic or different EMRs, they would boost you up a little bit more. So these are just some things that you can look at, and they would also help to send you to workshops that would provide additional CEUs that you can send to the governing body to add on so that you can maintain your certifications. So just keep those things in mind as well. Training and education, we're going to be exploring this a little bit more with different educational programs. There are virtual labs. Being that I'm a techie and I love that kind of stuff, I highly encourage getting onto the virtual labs and looking and seeing what they're about. They're fun. It just shows you what you can do. The possibilities are endless. And of course, I have already provided this on the site, but there is a career map where you can go and kind of like fix it how you want. You can work the hours that you like. You can do things that benefit for you and your family. All right. So once again, here's my endless plug to make sure you go back and check that out whenever you get a moment. Okay. There is a foundation where they provide research. So there's always going to have to be someone to kind of set the standard. We can't just pull it from the air. There's got to be research to show that this is working and this isn't. I can tell you that when Epic first launched with Rady Children, which is going to be my big basis, I love that hospital, but one of the biggest frustrations when we implemented Epic, which is our EMR system in 2008, whoever created it didn't speak to the healthcare providers. So when we were in the operating room and we were doing a procedure where we didn't have to cut the skin, well, every mark that had to be done was, where was the skin incision? Well, when you are taking out tonsils, we're not cutting into the skin, and we had to communicate with those. This was prior to me going into the field, which is probably why I went into the field. And we had to kind of help them be like, hey, not every case has this. Can we work with you to make sure that we are researching what works best for this facility? And of course, we got things fixed out and the kinks got worked out, but it's good to kind of communicate with that, do your research prior, so that when you're doing your workforce development, you're able to kind of not have to go back and do rework, right? It just made it frustrating for not only you who's implementing and helping them, but it also made it harder for the staff because they're like, I just want this to work. And you got to keep in mind that not everybody is tech savvy. I'm learning. That was one of the biggest things when you do go to a new facility. Keep that in mind, that there are going to be some people who are going to be resistant. And you have to kind of be like, okay, tell me why you are hesitant to this, put on your smile. And then you're like, okay, but right now it's taking you an hour and a half to fill out this record. But if you do it this way, you're done in 15 to 20 minutes with less errors. So that's some of the things you have to think about when you're doing research and workforce development. There's scholarships and different apprentice programs. You can check that out at the foundation, ahimafoundation.org, which is on the screen. And that is chapter 1 in a nutshell. So any questions before we move on? Let me see. No questions, we're good. Okay, so let's keep moving. Now we're going to talk about different healthcare delivery systems. In the United States, of course, there's lots of healthcare systems. We have preventative care, we have complex procedures, individual contacts with healthcare systems. Mary Birch is going to be a little bit different than Rady Children's. That's going to be a little bit different than Balboa. That's going to be a little bit different than the hospitals at Camp Pendleton, et cetera, et cetera. There are about 16 million healthcare workers in this healthcare system. That is a lot of individuals. And believe it or not, as you go into healthcare informatics, you are going to be a part of that healthcare system. You're going to be some of the bases. I think of us as the root to the tree, because we are actually helping set the foundation to make sure that the healthcare system, the healthcare delivery system, runs and operates to minimize errors, medication, wrong sites, et cetera, et cetera. We have our doctors, but a lot of people, when they think of doctors, they just think of MDs. I can attest to you that there's a lot more. You have your MD, your ODs, your DOs, your podiatrists, that all go into that example of doctors who practice, okay? Medical practices vary from so much, from internal medicine, pediatrics, family care, cardiology, ear, nose, and throat, neuro, oncology. For surgical specialties, for me, for example, I have a lot of experience in orthopedics. I started off doing total joints in the body, not joints. Just want you guys to know, like total joints, like, bones in the body. And I loved it. I moved to neurosurgery. I've, of course, done pediatrics for the last 8 years, but there's so many different surgery specialties that we will be involved with, making sure that we understand what the surgeons need, what the techs need, what the nurses need, so that we can implement the correct information for them. Of course, you have your nurses, your LPNs, your registered, your associate, your bachelor's, and your master's. They don't have masters on there, but there's also masters in nursing, and even postgraduates when you're talking about your nurse practitioners, and they have special needs as well. So it's so important for us to make sure that we understand our customers, what they need, so that we can implement or code or whatever we decide to do works for them. And then, of course, our allied professionals. They're the ones that I consider our workhorses. They're the ones that are on the ground. They're our soldiers. They're the ones doing the clinical laboratories. They're the ones running the labs from here to there. They're the physical therapists, the respiratory, the health information management, right? That's one of us. Your emergency medical technologists. They're the ones on the ground. They're the ones running. They're doing it. So they're going to be the ones that's really, really impacting, because they are going to be knowing exactly what is needed. Now, we're going to get into a little bit of organization and operation of modern hospitals. I'm bringing up modern hospitals because as we change, from the traditional approach of everything, you're starting to see a new type of hospital come up. I actually saw a commercial the other day of this hospital where you come in, they take your temperature, you don't see anybody. You walk through the door, you don't see anybody until it's time for you to go back. You look into some scanner, they scan your temperature, they say have a seat from some window, and then you walk in to talk to your physician. How crazy is that, right? But when we're talking about IDSs, we're talking about an integrated delivery system. This is where facilities under patient holding companies, where there's incentives, where the delivery system is leading to improved medical care and the quality of controlling costs. So they're trying to really shrink the cost. I can attest from being in the operating room that we waste a lot. Medical waste is so huge. It's so huge. And so they're trying to really knock it down. We have continuum of care, where we have local planning of bodies that coordinate and service funding for like homeless families and individuals. It's more of a strategic system where we're looking at the individual and finding out what would work best for them. Does that mean we have to provide housing? Does that mean we have to look at different services, the ranges? But we're looking at the individuals and what we can do to help them continue their care from once they leave the hospital. Think of a patient that has just had a total knee replacement. They can't really just walk out of the hospital. They're going to need rehab. They're going to need a nurse care. They're going to need somebody to help them to be mobile until they can get back to their active daily living or their daily living activities. Okay. And as you guys can see, $3.5 trillion, holy monkey, 17.9% of total American economy is dedicated to health expenditures. And the crazy part is, I mentioned medical waste. We do waste a lot. So just keep that in mind, when we're talking about, the healthcare system and the amount of money that we use in it. Now, let's get into that modern hospitals. Hospitals are changing, okay? When we're talking about organized medical staff, we're looking at how many inpatient beds, we're looking at around-the-clock nursing services. We have a lot more people who are providing their elderly care at home and providing a stay-at-home nurse or someone so that the elderly member can be with the family, as opposed to before where there were more nursing homes and individuals that way. You have your acute care hospitals where you're looking at an average stay of 25 days or less. You have long-term hospitals, you have hospice, you have inpatient, outpatient care. So we're kind of changing from that traditional, you go to the hospital, you get fixed in the hospital, you get rehab in the hospital, you go home. Now there's different ancillary services that are being utilized. So they're going to need specialized integrated healthcare systems to work for them. When we're looking at classifications, however, you're looking at how many beds does this hospital have? What makes this an acute surgery center? Is this a private plastic surgery center? Or is it just a walk-in clinic? We're talking about, is the patient going to have to be rehabilitated? I mentioned that patient with the total knee. So of course they're going to need rehabilitation. When a patient gets an amputation, a lot of times they need psychiatric care because you have someone who, let's say for 40 years was walking around with 2 legs. Now they only have 1. So they may need a little bit of adjustment. So the information that we provide as far as an electronic system for that psychiatric provider is going to be a lot different from what we would provide for rehabilitation. The patient may be the same, but the needs of the provider is going to slightly differ. So you guys kind of understand that, right? Like, we're going to be looking at our base. Who are we providing this information for, and what information do they need? We look at government-owned, proprietary, and voluntary. When I think of government-owned, you're looking at federal hospitals. A lot of hospitals are federally mandated. In the state of California, you look at how some substances are legal, so I'm gonna say. But once that individual who was doing the legal substance in that facility or at their home or whatever, once they step onto that hospital that's federally mandated, they adhere to the federal law. So when we're talking about updating different things in the electronic system, we're making sure that we are adhering to the facility and their governing body. Okay, now there are a couple levels of hospitals. I provided this up there because I'm a visual person. Like I like to see different things. So I like to kind of have an idea of what I'm looking at. You know, it's easy to say you have a level 1, a level 2, level 3, but what does that mean? So I put this up here so you can kind of have an idea of what like a level 1 hospital would consist of when you're talking about medicine, pediatrics, OBGYN versus a level 2 and a level 3. Why is this important to us in our field? It goes back to knowing your customer, knowing what type of information we're providing for them. A level 1 hospital is going to need different types of information provided to them as opposed to a level 3. Okay. Part of a Balanced Budget Act of 1997 is something that I think you guys need to knock and know. We're talking about specific criteria were met for us to even be able to classify these different hospitals in the levels that they are. You are looking at how the systems are getting paid back. You're looking at the ancillary services that they provide. Some places you have to furnish a 24-hour emergency care system or an ER, right? Because you can't have a hospital in some places considering yourself a certain level and there's no emergency room. Who are they going to treat? How are they going to get taken care of? You have to maintain no more than 25 inpatient beds and sometimes of the criteria, as well as be located within like a certain miles from the hospital. So these are different things. I'm gonna leave this up a little bit. If you want to screenshot it just for your own notes, you can. You're not being tested on this at all, but this is just, I like to provide ancillary information because I like that kind of stuff. So this is just to kind of like, if you have wanted, you're curious, well, this hospital is saying they have a level 1. What does that entail? This hospital says they're level 3. What does it entail? You guys good? I don't want to move on unless everyone's good. Perfect. All right. Organization of hospital services. So with every institution, there's going to be some type of organization system where you're looking at a chain of command, board of directors. So this is pretty much just a regular hospital chain of command, starting from your environmental services all the way to your chief nursing officers, to your XO, COO, CO, and then your board of directors of trustees. And a lot of this is probably a review. Now, managed care. It's a generic term for healthcare reimbursements. We're talking about how people are paying, the reimbursement, the costs, and the quality, and what services they can even get to. You're talking about access. You have health maintenance, where someone who, let's say, has diabetes, and now they're having to get medication to keep their diabetes from getting worse, hopefully help it get better. You have provider organizations, point of service plans, where I am looking at this and this is what I want as far as what I'm going to get for my healthcare. I'm going to pay for A plus B. Can I get that in my plan? One thing that you guys will notice is my sister, she's a massage therapist, and her husband were looking for an EMR. And I was able to provide her information pro bono because I love her. I'm thinking, no, I love her. I provided her information for a system that works for her and her husband because they are healthcare providers. However, they didn't need all of the extra, they needed more of a point of service plan. And you'll be able to help different people with that particular scale settings. You're looking at control costs, access, promote. You want to make sure they can promote high quality. Come to me. That's what you're getting your customers to do, putting them out there and providing services so that they can provide services for their customers or their patients. Sometimes they want to negotiate fees and they don't. You're looking at Medicaid, Medicare, different things that you can put into place to help them provide the best care for their patients and their insurance companies, et cetera, et cetera. There are 3 models. Once again, I like to have pictures. So where we partnership with hospitals and physicians, there are 3 models. You have your provider driven, your MCO, your MCO driven, and then your regional community partnership driven. when you're looking at your provider driven, that's just what it is. Your providers are the ones at the wheel, they're driving. They collaborate with networks and they assume the accountability of the cost of the care. When you look at provider driven, I want you guys to think of ambulatory surgery centers. A lot of ambulatory surgery centers are owned and operated by physicians. The physicians come together, they put their money in a pile, and they provide the services of their skills. I mentioned that I had worked at a surgery center and we did a lot of orthopedics. We did orthopedics, we did a little bit of plastics, and we did pain management. But it was together with a bunch of surgeons and they were the ones doing it. So their EMR was going to be a point of service because they provided only a certain amount of surgical specialties. Okay. And then when you're looking at these different things, when you look at MCOs, they're going to retain financial risk, but they implement new payment models in partnership with different providers. They're going to be a little bit bigger. You're looking at hospitals, you're looking at surgery centers that are a little bit bigger that are part of a hospital. For example, you have Sharp Grossmont, and then you have the ancillary surgery center of that. It's not provider driven, it's an extra of that particular facility or hospital. Other types of healthcare services, you have private medical practices, primary care, medical or surgical specialties, freestanding office settings. I'm going to throw out another movie, a TV. This COVID has been horrible because I'm watching really bad movies, TV series. But The Private Practice, which was a spinoff of Grey's Anatomy, right? They were a private practice. They were also owned by providers, right? And they had specialty care. So when you start looking at things, you would think of Grey's hospital as the big hospital, and then private practice is not a part of it, but it would be, you know, they did have some type of primary care and different things. You have medical homes where you have patient-centered, you're looking at the patient as an individual. We're focused on the quality and safety of the patient. These are more hospital care services, ambulatory care. You're looking at community-based, freestanding ambulatory care centers, surgery centers, different things like that. So a lot of this is going to just be the types of healthcare services that you could potentially be providing services to. You have your public health, your HSS. So it's the principal federal agency. 2 units, you have your Office of the Surgeon General, and then you have your ODPHP, which is Office of Disease Prevention and Health Promotions. Home care, if you want to work at home care, you can provide different services for them. Somebody still has their phone, everything on? Okay. All right. You have subacute care. These offer patients access to nursing care while they're recovering from home. So the last one would be like that patient that had the total knee arthroplasty, the total joint replacement. They're going to need somebody at their home. So when you look at these different facilities and things that healthcare services, you're looking at what would you have to implement for them. So start thinking about that. For a home care service, you're going to implement something way different for a person that's there for constant nursing care or recovering home. Then we're talking about long-term care for a patient that's going to be home for a lot longer, you know, whether, now we're not talking about hospice, but we're talking about long-term care. The easiest example I can think of is Superman. You know, when he fell off of his horse and then he had to be in his wheelchair and everything like that. Well, he had long-term care because he couldn't do anything for himself, right? And so Christopher Reeve, you guys know him, right? I'm not too old. I'm not saying anything you guys don't know, like Superman. Okay, I'm trying to make sure. He had the long-term care. So, you know, you're being more supportive, not necessarily rehabilitative, because, you know, his situation, he wasn't able to be rehabilitated, but he did need that supportive, and it was non-curative. So these are just a little bit of the things that, you know, you may be, if you choose to, be working with. Now, we're not just talking about physical care. Sometimes you have to be looking at other things as well. Behavioral health services, where you're looking at individuals that may have other undefined mental health issues. When you implement things for those particular facilities, it's going to be a lot different, right? Their systems are going to need a slightly different type of, implementation of what they're looking for. You have long stay, residential, government, day hospitals, just different things that you're going to have to kind of put in the back of your mind. Now, we're looking at stuff that we are starting to see more and more of. When we look at telehealth and we look at electronic health records and healthcare. With telehealth, we're looking at the use of electronic information and telecommunication to support and promote long distance clinical healthcare. You can see from the picture, here's someone who's talking to her physician or her nurse or her practitioner, and they're able to communicate via telehealth. And then when we look at the electronic health record, it is everything that was on that piece of paper. Now it is at your fingertips, either on your phone, your iPad, etc. It has big data, large amounts of data. I always call it the cloud. And it can be used for analytics. You can look at a patient, for example. There's going to be times where they may say, hey, I need you to go ahead and get all the statistics for this particular doctor. And you're like, okay. Well, they're looking to see that, let's say 10 of their patients now have MRSA. What's going on? Where all of the other providers, nothing's happening, but they're asking you to get this information for them because out of those 10, 4 didn't make it. So it can be used as a really good thing. Okay, now we are at 5:57. We have a couple more slides, but I'm going to go ahead and go on a break so that we can shake it off. And I want you guys to all come back in 10 minutes. Okay, go ahead, take a break, go get some water, stand up, shake it off. And then I will see you guys all back in 10 minutes. Okay. All right. Okay, so I wanted to just finish up with nothing is impossible. The word itself, as I said, means I'm possible. I want to reiterate some of the things that are due. If you have not jumped into your discussion forum, jump in there, okay? Knock it out. Knock out your knowledge checks. Get 100%. Do it as many times as you can. Our Zoom sessions, you will meet me every Thursday, and we're going to try to have some fun. Today was kind of an introduction, kind of getting to know me, you guys actually seeing my face versus my avatar, and really kind of us coming together for this field. You have your checks, your feedback. Make sure you guys take that feedback. I'm super excited to have all of you all here. I'm super excited to hear even further once you're done with this particular course, where you're going to go in your career field. I know that this field has been very rewarding for myself, and I'm hoping and praying that it's just as rewarding for you all as you start this new journey for wherever you are in your life, okay? You do have your agendas will pop up, so make sure you hit that button to see who is in store to give you the agenda for the following week. And I am excited because I think you guys are going to like who's going to be here next week, all right? Do you guys have any questions for me? Anything that you had? I'm super happy to finally meet you all in the flesh. And real quick, if you guys send me an email during the week, if I'm not able to get to you, it's probably because I'm either scrubbed in, but just know that I will get to that as soon as I can. So I don't want anyone to ever think like, oh my gosh, she emailed me, I wasn't able to get back. It's just because I'm probably either scrubbed in or I am, in the operating room doing something. But I will be able to get to you when I can. I do have my electronic device, so I am able to check it. And if it's something computer related, sometimes my cell phone it's too small, so I'd have to wait till I get to a computer or whatever. So I'll either send you a message and say, hey, I'll get to it when I am able to get to it at a computer. Okay. But in the evenings after 5 o'clock, you can always reach me. Okay. So you can send me an email. I'll be able to respond back to you. Unless my toddler is running around doing something crazy. If no one has anything, welcome. Happy New Year. And I will see you again next Thursday in the flesh. Thank you, guys. Adios. Nice to meet everybody.
Professor?